great pleasure to be here. So what I'm talking about is a little bit sort of a mixture of scientific and clinical, and I would be happy for you to interrupt me at any time, but maybe for the people who are viewing online, it's easier if I give my talk and then if you come with your questions afterwards. So I'm a practicing psychiatrist. I'm also professor of neurotechnology at the University of Cambridge here at Chemical Engineering and Biotechnology, just off Mattingley Road. A little bit of a strange combination. I'm still seeing patients as an honorary consultant psychiatrist. And my passion really is to improve the diagnosis and treatment of people with severe mental illness. And I just want to point out the enormous unmet need that we're having. So 10% of the population is affected by schizophrenia, bipolar disorder, or major depressive disorder, which are called the major psychiatric disorders. And actually 1 in 4 of us will have had or will have a psychiatric diagnosis during our lifetimes. So it's a quarter of people who will suffer maybe from an anxiety disorder, from adjustment disorder after bereavement. Some of us may develop dementia as well. So many of us will be affected by mental disorder, by psychiatric disorder. And indeed, almost a quarter of the years lived with disability are associated with psychiatric disorders in the Western world. And it is responsible for 20% of the burden of disease. We know that early intervention, early diagnosis improves outcome. And this is really what I'm about. I want to be able to work towards an earlier diagnosis, particularly of schizophrenia, which has been my previous work, and now also bipolar disorder. And this talk will be focusing on bipolar disorder. So bipolar disorder affects about 3% of the population. In the UK, it's about 1.9 million who present with a depressive disorder, usually to their GPs. But 10 to 20% of them are not suffering from depression, but from depression in the context of a bipolar disorder. And I will talk a little bit more about the diagnosis of bipolar disorder in the next slide. On average, it takes about 7 years until someone gets diagnosed, because people who have bipolar disorder, whose moods are going up and down, usually only see a doctor when they're low in mood and depressed. They're not coming saying, I'm feeling great, I feel on top of the world, I'm super effective. But they're coming to their doctors when they're depressed. And if the doctor, the GP, has only 5 to 7 minutes to ask a patient about their symptoms, they usually will not ask, have you had a time when you felt great? They will be focusing on the low mood and they prescribe an antidepressant, which is done very quickly. But unfortunately, someone with bipolar disorder and who is depressed at the current time, if you give them an antidepressant, they may actually switch into a manic episode. So the doctor can do real harm here. And also, if they don't go high, they may not respond to the antidepressant medication because bipolar depression needs to be treated differently. So we prescribe mood stabilizing medications, which was traditionally lithium. These days, it's also certain antipsychotics and certain anticonvulsant drugs, which are helping to stabilize the mood. And this eventually, hopefully, helps people sort of to get better, and also stabilize them and stop them from going either up or down. So 60% of people with bipolar disorder are initially misdiagnosed, mainly with depression, but also sometimes with personality disorder, with all sorts of other conditions. And usually the onset of this disorder of bipolar disorder is in late adolescence, early adulthood, students, young people. They behave then, if they're manic, completely irresponsible. They may engage into inappropriate sexual behavior. They may do silly things, dangerous things, may have accidents. They may drop out of education. They may become criminals, addicted to drugs, because this is part of being manic, that you're just behaving irresponsibly. And all of this could be avoided. So it's very, very important that we diagnose people with these conditions early on. Don't forget, it's almost 3% of the population, so it's a lot of people. So if people don't get diagnosed, they are more prone to not only get ill, but also commit suicide. About 15%, 10 to 15% will kill themselves. And the concordance rate amongst identical twins is about 80%. So there's a strong genetic component. It's also important to ask when people have a family member who has been suffering from bipolar disorder. So these are just sort of some diagnostic classification. We have on one side a unipolar depression, which is people only going down and then they may get better on treatment or with, without treatment. And then they have other episodes of down. So it's usually a recurrent depressive disorder. On the other hand, we have bipolar 1 disorder, where we have really highs, where people may be psychotic, they may be delusional, they have grandiose idea, they believe they are a special force, they sometimes talk about being in hyperspace and doing things, and they feel absolutely wonderful in themselves. They don't need any sleep, they do reckless things, and they usually crash down sort of afterwards. Bipolar 2 disorder is particularly difficult to diagnose because people have deep, deep depressions, and then just mild elation in mood where they feel more effective at work, they have lots of energy, they're working more than usual, and only people who know them very well would say, he's a little bit up, he's a little bit high, but it's very difficult to diagnose. So these are not milder forms of bipolar disorder, actually often more difficult to treat. Then we have the cyclothymia and bipolar disorder, not otherwise specified. This is just diagnostic categories, which we usually don't use, but this is more where people are sometimes a little bit up, sometimes a little bit down. It can be sort of part of normal personality traits, but at the other ends, the extreme ends, we have a disorder. Disorders always associate with impairment, and that has to be present. And with cyclothymia, most people can manage. Sometimes they need medication, but most of the times they can manage. They learn how they are and they can deal with it. Here, this is just showing you that again. So bipolar 1, these high ups and downs. Bipolar 2, just these mild ups. And in unipolar, you only have the depression. But this graph is really not really telling the whole story, because 80% of the times people with either bipolar 1 or bipolar 2 disorder have actually depressive episodes. Only very rarely do they go up. And this is again why you misdiagnose bipolar disorder so frequently, because they may have had a manic episode 5 years ago, sometimes even longer, and then they had lots and lots of depressive episodes, and it's very difficult in talking to a patient to get to this high episode and elicit that properly to then make the correct diagnosis. And without the correct diagnosis, you can't treat them appropriately. So if someone is really manic, the symptom is they're distractible, they're jumping from one topic to the other, they can still usually follow things, they have increased activity, psychomotor agitation, they can't sit still, they jump up and down, they have grandiose superhero ideas. I had a young student cycling on the M11 because he thought he was in hyperspace, he was enacting the Fifth Element. Flight of ideas and racing thoughts, they come very, very fast. They talk about 10 things simultaneously and then are surprised if people can't follow them. And they can be hypersexual, so inappropriate sexual behaviors, which afterwards obviously puts them in a very difficult position. They may expose themselves publicly, and this can obviously damage their reputation. They don't sleep at all. They don't think they need sleep, but eventually they can also then become psychotic, delusional, they can hear voices, their speech is very pressured, and also overspending. I had patients who bought houses, their mother's card, sort of, and terrible things, and 2 cars, and then afterwards you have to pick up the pieces at the end of this episode if someone wasn't caught early enough to, usually in this case, be sectioned and taken into hospital until they stabilize again. So it can be really devastating people's lives dramatically. And Sylvia Plath, who herself suffered from bipolar disorder, described it. It is as if my life were magically run by 2 different currents, joyous positive and despairing negative. Whichever's running at the moment is dominating my life, floods it. So it's this exuberance and then the deep, deep fall into the depression. So my research has really focused on trying to establish the biological basis of these disorders. We all believe this is affecting the brain and therefore the cause needs to be in the brain, but this doesn't necessarily have to be the case. And we know that people with psychiatric disorders have higher comorbidities, for example, with diabetes, with rheumatoid arthritis and other conditions as well. So there's a lot of evidence from the past, also inflammatory diseases, that psychiatric disorders affect the whole body. but the presentation and the symptoms are more obvious as they affect their cognition. So it affects the cells of the body, but there it doesn't cause much symptoms, but in the brain it causes these symptoms. If you look at the post-mortem brain of someone who died with bipolar disorder or schizophrenia or severe depression, there's very little change. It's very subtle. It's not that structurally there's much wrong there. But it's about the cell communication where the problem lies. And this is also very difficult to elicit. So it's not like Alzheimer's disease, dementia, where you can see when you image the brain that the substance of the brain is decreasing. This is not necessarily the case for psychiatric disorders. So I have been looking at post-mortem brain. I had the privilege to be supported and funded by the Stanley Medical Research Institute from the United States, and for all of my career, really. And they have the largest brain bank as well, with several hundred post-mortem brains of people with psychiatric disorders. So I used omics technologies to look at the changes in proteins, in metabolites, and also gene expression to try to identify abnormalities. And we found changes in how the brain is utilizing glucose. The metabolism of the brain seemed to be altered. And I haven't got the time to go into too much detail, unfortunately, but basically it seemed the brain is not getting enough energy. And one has to understand the brain is only a few % of our body weight, but it takes about 30 to 40% of the glucose in our body. So the brain is enormously greedy. It takes almost half all of the energy what we're eating goes into our brain. And the glucose has to be transported actively across the blood-brain barrier. Because there's the blood-brain barrier to protect viruses or pathogens to go into the brain. It's a very privileged space, obviously, because we need it very much. So the glucose has to be actively transported. And this is no other cell in the body or other organ where this barrier exists. So it could be that in this state, in this mental state, the genetic predisposition, if there's a higher need for glucose because you are agitated, some sort of mechanisms are ongoing at the cellular level, not enough glucose can be brought into the brain. And what we saw in our post-mortem brains, as if the mitochondrial function was not sort of intact, that basically the brains were starved of glucose. And in the brain, glucose and the reduction of oxygen are equivalent, because the brain hasn't got the capacity to go into anaerobic respiration, which our muscles can do when we then get our muscle aches because there's too much lactic acid. But in the brain is very much dependent on glucose. It can't easily utilize alternate energy sources. So not enough glucose is basically hypoxia. And maybe this is then precipitating these symptoms. And this is a theory which I think sort of has been more widely accepted. We were amongst the first ones to see these changes in the post-mortem brain. So then I wanted to see, can we also see changes in the cerebrospinal fluid? So I had a collaboration with Cologne at the time, where they collected cerebrospinal fluid from patients who presented with psychotic symptoms. And before they were treated, both blood and cerebrospinal fluid was collected, because in certain regions in Germany, there's a high rate of borreliosis, and you need to check because it's a treatable infectious disease which you can treat with antibiotics, and therefore the cerebrospinal fluid could be collected without the patient's consent at the time. And then afterwards, the consent would be collected from the patients. Are we allowed for research purposes to use this? And this is what we did. And we found some of the biomarkers that we found in the brain, and then we moved on and we looked also at peripheral tissue, in particular blood. And obviously for diagnostic test, blood or urine or something which is more readily accessible is much better than having to take out the brain sample or cerebrospinal fluid, which is very invasive. And so the technology that we used was really eventually mass spectrometry. So we looked at different technologies, and with at the protein level, we saw most of the convincing biomarkers which were at least promising. And we looked, as I show here, we looked at, how does it work? we looked at brain tissue, we looked at animal models of psychiatric disorders, which are all not perfect, and then we looked at different body fluids. We used a shotgun approach where we looked at all the proteins in the proteome. We digested the proteins, the tissue, the blood samples with enzyme, which is called tryptic digestion, and then we could look at all the different proteins in the mixture. Then we saw that some proteins were more present in a disease than in a control population, and others were higher or lower. And then we had to validate them with orthogonal technologies. In this case, we used in particular multiplexed ELISA. This is enzyme-linked immunoabsorbent assay. So these are, we have an antibody and a sandwich and a second antibody with a light marker, and then we can see how much of the protein is present. So in the screening technology, we look at lots of different possibilities, and with these orthogonal technologies, we can quantify it. And we also used another mass spectrometer using a method called multiple reaction monitoring, which is a different approach, which you can see here. So that doesn't matter too much. It's just we looked for differences in proteins in the blood of bipolar patients as compared to controls, and also in schizophrenia and in depression. And then we looked, can we identify and separate the patients from the control population based on blood biomarkers? And for this, you then use a machine learning algorithm ultimately. But what you use in order to describe the accuracy of a test is really a receiver operating characteristics curve, just showing you here because that will be coming up later. And you can see something which is around 0.5. The blue line in the middle is basically like tossing the coin. This is a random output. Something between 80 to 90% is good, it's 0.8 to 0.9. And obviously 1 is an excellent, it's 100%, but you usually don't achieve that. So we were looking for biomarkers which help us to diagnose psychiatric disorders, in our case here, and particularly bipolar disorder, differentiating unipolar from bipolar disorder, because that's the big clinical question. Someone coming in with depression, and then is this depression in the context of bipolar disorder, or is this depression in the context for bipolar disorder? And then we want to have biomarkers. So initially we used multiplexed ELISAs, as I just mentioned. This is very complex, and we got good findings, but the tests are very expensive because assays for 20 biomarkers is costly, and it's also not very stable, because each time you replace one of the antibodies against one of the 20 biomarkers that you're interested in, the sensitivity and specificity of a test shifts because it has a slightly different accuracy, and this caused quite a lot of problems. Nevertheless, we worked together with a big company in the US who was quite interested in that, and they sort of took the patents and interest in these tests, but I don't think too much for any disorder has come to market yet using this platform, because of it's a little bit of a shifting sand sort of platform. If you have this multiplex ELISA, not with monoclonal, but with polyclonal antibodies in particular. So in the lab, we had the idea of using dried blood spots. The tests where you use ELISA, you have to take blood from the vein, you have to spin it down, you have to, basically sort of put it on dry ice, and you have to ship it on dry ice. So before the sample is analyzed, it costs already around $500. So it would have been very, very expensive. So I had the idea that for newborn babies, we still use the PKU test, the phenylketonuria test, where we have a pinprick blood test from the baby taken from its toe. And this is sent to the laboratory using mass spectrometry, similar to our tests. They then identify if the baby suffers from this condition, and then you can treat it. So I thought, let's try that as well, because the technology for that is available. And dried blood spot can be collected at home by the patients themselves. They're easy to collect, easy to store. They don't need to be frozen. They last, if they're in a desiccated, dry environment, forever. So there are large biobanks, where there are 50-year-old samples. You look at them and there's very little degradation. Most of the proteins are very stable. You don't see the same proteins that you see with the ELISA technique because you see more abundant proteins with these technologies. You don't see the cytokines, the proteins which are not very stable. But this is maybe not a bad thing with a test that you want to be very robust and you need very, very little blood. And this is the platform that we developed. We developed an assay platform with 120 proteins represented by 203 different peptides. Peptides are the little pieces that the proteins are made of, and we were able to measure them in our dried blood spot samples. I will not go into too much detail about that. And then we tested, can we differentiate unipolar and bipolar depression in the Delta study, which took place from April 2018 until October 2019. And the approach was that we wanted to combine this blood test by the collection of a dried blood spot together with a digital assessment. By the digital assessment, we wanted to assess the symptoms that the patients have experienced in the past in terms of potential manic episodes. It's basically an extensive questionnaire. We ask questions about their personality. We ask questions about other relevant psychiatric conditions, anxiety disorder, substance use, alcohol use disorder, family history, about trauma history. So we collect a really extensive story from a patient digitally. Over 700 questions initially, which were asked in a non-linear way. So if a patient was asked, have you been low and depressed? And they say, no, we will not ask them the next 100 questions about currently being depressed or having been depressed in the past. So it should only present relevant question to the patient. And then those who fit into our research criteria, so who had a diagnosis of depression in the last 5 years, we would ask them, would you also be happy to provide us with a dried blood spot sample? And we would then send them this blood spot kit with we had a YouTube video where they could see how the blood can be collected. Then we also had a little leaflet where they could read what is expected now after Corona. We all know how to do these things, but at the time, sort of, it was important to guide people clearly what is expected, and then they ship them back to us. And the primary endpoint was to identify bipolar disorder in people who have been diagnosed with major depressive disorder in the last 5 years. So we wanted to see and identify those patients who had been misdiagnosed. The secondary endpoint is to identify both major depressive disorder, here MDD, or bipolar disorder in people who are symptomatic with mild depressive symptoms, but have no previous diagnosis of either depression or bipolar disorder. And we wanted also at least 40 patients who have a diagnosis of bipolar disorder by a psychiatrist. So we wanted 400 patients with a recent major depression diagnosis, 400 with a low mood, not previously diagnosed, and also 40 people with a bipolar diagnosed by a psychiatrist as a control group. Then we did the whole assessment online, eligibility on consent was online. Then a digital questionnaire was delivered to patients. This was in 6 different sessions, and those who met these inclusion criteria, which I just mentioned, were sent dried blood spot collection kit. And then we trained 10 ladies to deliver a structured clinical interview, which was developed by the World Health Organization. We had trainers over from the Netherlands to train lay people how to deliver a psychiatric interview through the telephone. They had to just read it out, and then it's basically an algorithm, and it's just reading out and then clicking on the answer that the patient gave. And then we had the 6 and 12 months follow-up of patients as well. So this is just a little bit more detail about the CD interview, the structured clinical interview. So it's comprehensive, fully structured. So from decades been used and validated, has a reasonably good sensitivity and specificity, can be used by lay interviewers, doesn't have to be a healthcare professional, and has a history of good quality and consistent data, which again, published and reproduced many times over. And the successes of the Delta study were that we had within 6 months over 40,000 visits to the trial site. We didn't give people any incentives. They were not paid for it to give us their blood samples. So it was amazing how many people were interested. Over 5,000 people participated. We collected 1,400 blood spots. Almost 1,000 CD interviews were completed, and we delivered reports. So we were able, under ethics, obviously, to tell patients, thank you for doing the study. You answered these questions, and based on these questions, these and these diagnoses could be indicated. We also provided them with personalized psychoeducation relevant to their symptoms and other information of self-help, etc. We developed on the basis of these data some broad set of diagnostic algorithm to diagnose and differentiate unipolar and bipolar disorder. We got very good feedback from patients, and we developed this platform under ISO 13485. We CE marked the blood spot collection kit, and it turned out to be a stable and scalable platform. And this is the feedback. So almost 80% of patients felt it was very useful, or somewhat useful at least. Some patients didn't find it useful. We had a lot of feedback for them. Some of them said, oh, I didn't find it useful. It just told me what I already knew, that I had depression. So that would be still for us sort of useful. So very positive feedback overall. And then very interesting was the 6 and 12 months follow-up. And the objectives for this were to assess the impact on quality of life for the participants. So we did a quality of life assessment at the beginning, and then at 6 and 12 months. So quality of life is a well-being scale. It's called the Edinburgh-Warwick Well-being Scale, where patients are just asked, how satisfied are you with your life? Are you able to enjoy time with your friends? Are you able to work? Are you able to enjoy hobbies, etc.? It's just, is someone having a quality of life? And then you get a score for that. And we wanted to see, is this changing before and after the intervention? We asked them also, has their mood diagnosis changed from bipolar to depression or vice versa? And we asked them, has your medication changed as a diagnosis was changed, to see whether how reliable this is. And it was very interesting. We did advertise for study participation in online media, Facebook and so forth. And we stated that we're looking for people who may have been misdiagnosed. And it was it's probably not fully representative, but we found that here in the low mood group, that 24% of the people in the low mood group actually met CD diagnostic criteria for bipolar disorder, and 36% for major depressive disorder. So these are people who previously had not been diagnosed at all. And amongst the group of people with a previous diagnosis of depression, over 30% have met diagnostic criteria for bipolar disorder. And reassuringly, most of the patients who have a previous psychiatric diagnosis of bipolar disorder did indeed have a bipolar disorder according to the CD diagnostic interview. What we found that the patients who had been misdiagnosed according to the CD with depression, when they indeed probably have a bipolar disorder, had their first depressive episodes much earlier than the depression group. Their symptoms were more severe, and they had a lower well-being score. So these are people who have more severe depressive symptoms. And this is also what we know from the literature, that there's a more melancholic, severe depressive presentations and at a younger age, which is prognostic for bipolar depression. And approximately half of the individuals with BD who were misdiagnosed with MDD had experienced hypomanic episodes prior. So we picked that up, so they could have been diagnosed easily had someone asked them these questions, but no one had obviously asked these questions about these manic or hypomanic episodes, these highs in mood that they had previously experienced. Then we did a machine learning algorithm, and we combined all the different features, including biomarkers, including symptoms that were asked in the 700 questions in the questionnaire. And to our, we were disappointed that our biomarker features were very low down. You can see here in blue the biomarkers quite far down, and on top, really, the symptoms and the features associated most strongly with the diagnosis of bipolar disorder were elevated mood, grandiose ideas in the past, obviously for most of them, because currently they were in a low mood episode, being more talkative at times, reckless behavior, risky behavior, etc. So this was very disappointing. We developed all this platform, measured all these proteins, spent a lot of effort, money, and our enthusiasm into developing these approaches. But really the traditional symptoms were very good at detecting disorder, and the proteins were quite low down. And here, featured in a ROC curve, you can see the biomarkers basically giving no signal whatsoever, whilst the digital assessment with the symptoms alone gave almost an excellent area under the curve. And when by combining them, the biomarkers are not adding at all. And if you then optimize the models, you have an excellent area under the curve for when you combine bipolar 1 and bipolar 2, an area under the curve in the excellent range also, and in particular for bipolar 1, which is a more robust presentation, and slightly lesser for bipolar 2, as we know with the milder manic episodes where people are just slightly more excited. It's more difficult to disentangle these symptoms into a syndrome. And we have very good sensitivity, specificity, and also accuracy of the test. But we did not give up. We had collected all these dried blood spots, and then I decided, let's look at differentially expressed metabolites. And we worked together with a company called Biomarker in Innsbruck. They are a leading company in mass spectrometry-based targeted metabolic analysis. They already developed their platform under aspects that you can then deliver a test very easily based on this platform because it's absolute quantification. They have a platform which measures 630 metabolites from the 6 different classes of metabolic groups, and they could measure these metabolites in our 3mm spots, which we cut from our dried blood spots. We shipped it to them, and they analyzed and sent us the results. And we were delighted when we did machine learning. This was Jakub Tomaszek, Dr. Jakub Tomaszek from my group, a data scientist who did the analysis. And here we see a clear signal that based on the metabolite biomarker signature using 67 patients who had the previous diagnosis of depression, who the CD diagnosed as bipolar, against 174 people who the CD also confirmed the diagnosis of depression, we could find a fair separation of these two groups. So we could differentiate the unipolar from the bipolar depression group based on a couple of metabolites. And there's a very strong biomarker, which is a ceramide. It's a sphingolipid. This is a lipid which is part of the insulation of the nerve cells, the myelin. It's involved in myelination. It also plays a role in neurodegeneration. So we can see abnormality in this in multiple sclerosis, but also in dementia. And we also see some other biomarkers related neurotransmitter synthesis, some other pathways, insulin resistance, energy metabolism, in line also with these observations from the post-mortem study previously. But the ceramide metabolite is very prominent here as a diagnostic marker. And when we combined that with the digital assessments, so included in these in our questionnaire were PHQ-9, which is a measure for depression, which a GP often uses, and also other aspects like demographic details and MDQ, which is also a screening tool for bipolar disorder. We can see if we add the biomarker to these tools, they significantly improve the probability of identifying someone with bipolar disorder. So we would not say that everybody who presents with symptoms of potential bipolar disorder or with depression should have this test. But if it is unclear whether someone has bipolar disorder or depression, particularly if they can't give a clear history of previous manic symptoms, this test could point in the right direction. And we are at the moment sort of starting a study to validate these findings. So this is very exciting to us, has been a major step. And then I want to just also talk to you and tell you about the follow-up results, which were very interesting. So it's the perceived usefulness of the study and what aspects patients found useful. And you can see here, patients who received the report of their potential diagnosis said as a consequence of doing the study, they were talking more openly to friends and family about their symptoms. They felt they understood their problems better themselves, and they were more proactive at seeking help in other aspects as well. And the aspects of the study which they found particularly important were the results. It was the personalized psychoeducation, and was also self-help advice. And we found from the 1,300 participants and feedbacks we got that about 16% of patients changed their diagnosis. Those who were previously depression, now I think it's 8% who had a new diagnosis of bipolar disorder, and obviously quite a number of the patients with depression lost their diagnosis. And we could also see that in their reported medication, that patients had done our online assessment. They went to their GP. The GP probably referred them to the psychiatrist, and then their diagnosis was changed, and also their medication was changed as a consequence. So this was very positive. And the most encouraging aspect for me was when we looked at the well-being scale. So patients just did this online questionnaire, and then they received a minimalist report under ethics. We could not go into too much detail, and some personalized psychoeducation. And when we did the well-being scale, where we looked at people's functioning, their well-being in everyday life, their function in everyday life, we saw a significant improvement both after 6 and 12 months. And this is as strong as if someone has had 16 sessions of psychotherapy. So just this report, people were talking more openly about how they feel. They were seeking help. They felt more validated in that, I can talk about it. I'm not a strange person. I'm not wrong in any way, but I'm suffering from a condition. I understand it better, and therefore I can seek help. And then as a consequence, they feel better and feel that they are not lacking. And I think this is very, very, very important aspect. And then on the basis of this study, we already sort of at the beginning have incorporated a new company, Psyomics. We are trying to help every patient onto the right pathway. Not only people with depression, bipolar disorder, we want to identify problems, and we want that people receive the most appropriate help early on. So Senseo has grown from the Delta study to a larger platform. We're now over 1,400 questions, non-linear delivered. We're assessing more conditions. It's a digitally delivered platform. At the moment, the biomarkers are not incorporated. This may come later. It's a series of adaptive questions. It's built on detailed picture of someone's holistic presentation about how often do you see a friend, how often do you talk to someone that you feel close to, because all of this is very important for mental health as well. It's how someone feels supported in their environment. If someone says, I only talk once a month or never to someone that I feel close to, that's not a very good sign. And then we have to be alert also in the mental health services. So this is streamlined assessment. It's replicating basically a full psychiatric assessment. It's helping in clinical decision making, and it's helping to send people to the right place, because many times people with mental illness, they are sent from one place to the other. first to psychological services. Psychological services identify someone has suicidal thoughts, then they say, oh, you know, this is too risky for me. Then they want to be seen by psychiatrists. They have to retell their story each time and are not being helped often for a long, long time. And this is, I think, where we can make a big difference. And here are the conditions that we are assessing in the Senseo platform, which is our diagnostic platform, which is now used in the NHS already. We are in several NHS trusts. We are also in private psychiatric care, and we're just currently trying to roll out into different places as well, where we see utility. We want to also deliver a product direct to customer, where patients can do that in their own place. They can check their symptoms. They can then seek help if they feel ready. And many times with psychiatric disorders, people don't want necessarily to talk to someone. They want to find themselves, can I sort it out myself? But at some stage, with the appropriate psychoeducation, they may feel they are now ready to seek help. So in the Delta study, we looked at bipolar disorder, we looked at generalized anxiety disorder, insomnia, obsessive compulsive disorder, panic disorder, social anxiety disorder. But Senseo, I will not read out everything. We look at almost all psychiatric conditions and cross-reference them. And we've done trials in primary care. We get good accuracy, sometimes excellent accuracy. This is obviously on a small number. We validate regularly blinded reviews of the reports and the outputs by psychiatrists, by psychologists. They look at the symptoms and say what sort of diagnosis they believe these symptoms would be associated with according to DSM-5 or ICD-10 criteria, which are diagnostic manuals that we're using typically in psychiatric care. So we feel that with our product, we're we're helping to overcome the increased demand that we have in the NHS. Services are overwhelmed, particularly in primary care. 40 to 50% of patients who are coming to see their GP, there's a component of mental illness associated with it, and they don't know what to do. Here, there could be a way of more easily identifying those people who most urgently need to be seen, because we're also assessing suicidal risk. We're looking at self-harm. We're looking at people who may engage in risky behavior. So we're not shying away from severe mental illness. We are really deep in there with the severe mental illness, not only mindfulness and the milder anxiety conditions, but really something, we're looking at psychosis, for example, as well. So we hope to reduce staffing pressure and help to triage patients in the appropriate pathway. Patients can do these assessments in their own time. They can come and go. They can think about the question. They can go backwards as well. And this is sometimes very difficult, because at your first appointment, if you're going to a psychiatrist, you're sitting there, you're very nervous, you're seeing a person you've never seen before. They will ask you all sorts of the most personal things, and to open up can be very difficult. Here they can do that in their own privacy, and they don't look someone in the eye, you know, who they haven't seen before. And this can be something, particularly for men, easier, because we see that many men don't come and seek help until they are very, very, very ill. And hopefully with this approach, we see more men coming through our doors, and we can treat them earlier as well. And this is how it works, the digital assessment. We have our algorithm, we have then a report, and the report is delivered to psychiatric services. So at the moment, our product is used in the NHS by the psychiatric services. So they have people on the waiting list, they send them the link, the patients does the assessment. They can then, the psychiatric nurses or doctors can look at the report, they can see this person is suicidal, let's call them straight first, so that we, you know, if there is a risk. Some people have milder conditions, they may have some anxiety, they may not need to see a doctor, they may be able to see a psychologist as well. So the clinicians can make an informed decision, because the tool helps to structure the need that presents amongst the people on the waiting list. And unfortunately in the NHS, this is what we're dealing with, lots and lots of patients on waiting lists, and you don't know who needs to be seen first. And I hope that we will be helping here for patients to get help And this is a report. It has changed already. We're always working, but you can see here information about suicidality, self-harm. Also, the patients can fill in, why am I coming now? What I'm looking for, what type of help? Why am I in a crisis? They can talk about, I am financial difficulties, you know, I'm about to be evicted, I'm homeless, etc. All of this information is obviously very important for us to see the context, because mental illness is not like a broken leg. You need to see the whole picture of an individual who's presenting at a given time with what symptoms. These symptoms have a context and we need to understand them. And then it gives a confidence indication of certain disorder here, for example, bipolar disorder. It outputs all the symptoms related to a diagnostic manual where a doctor would say, okay, yes, that sounds like bipolar disorder, but they can also make a decision. I think this could be something else. So we are not replacing a doctor's assessment. We're just giving structured information. Then the doctor or healthcare professional can themselves interpret. So we are not a diagnosis, but we're supporting diagnosis, in particularly the triage to patients to the most appropriate treatment and intervention. And we have over 8,000 patients have used Senseo. We have a very good up to 80% completion rate. In some services, it's lower. So we hope to change that as well by sometimes patients don't know where this link is coming from. So we need to make very sure that they know this is coming from your doctor, this is coming from the NHS. So there are some little tweaks that we have to do. People usually can do the assessment in an hour. Some people need more, particularly if they have lots of symptoms. If you see if they're alcohol use, depression, and lots of other conditions, then it will open up many, many trees of question. And we have a lot of uptime, and we've so far identified almost, as we believe, sort of 100% of the urgent cases. We've saved certainly life as well. And we are making impact. We have looked at the NHS trusts who we are working with, where the product is being used. We can help to structure, we can help to triage patients through the system and really deliver on our promise that patients don't knock on too many wrong doors, and we identify those who need help most urgently. And this is the end of it. Thank you very much. And I'm ready for any questions. Thank you.
That was fascinating, rather uplifting.
I think. Yes.
I'm sure there are going to be some questions. I know our hands going up instantly, so I'm going to grab the first one. Going back to your biomarkers, you were sort of tantalizingly saying right at the start that there might be a relatively straightforward generic problem about the blood-brain barrier.
Yep.
Is that's work in progress? There are some indicators you've got a biomarker that looks promising.
Yes, yeah. I mean, the ceramide looks very promising. This is a metabolite, but that doesn't relate to the blood-brain barrier. It's not a blood-brain barrier problem. The problem is that the glucose into the brain has to be actively transported. But the ceramide is a myelin protein. It is also present in the peripheral tissue, and we don't know whether this is coming from the brain, but it seems to be correlated with the disease. We don't know exactly the functionality. That's always difficult then to be sure of.
And it doesn't point towards a therapy?
So this is a very good question. What we found, if we looked at people with bipolar disorder who have been treated, the biomarker was slightly lower. So it seems to be more present if someone has not been treated. That would obviously open many more opportunities as a marker of response to treatment. But for this, you need longitudinal studies. Quite difficult to collect these samples, but this is something we will be interested in.
We've got some questions online. Should we take a question from the floor first?
Yes, my name is Liz Hales. I was just asking whether this tool has been used at all within the criminal justice system. When people go to court, there are often issues of mental health, and a very high percentage of the prison population is holding people with mental health issues. But getting psychiatric assessments done is very lengthy. And the person is often remanded in custody until that's completed. And assessments of risk of suicide are very basic within the custodial estate. And I think it's one area that would be worth pushing to see if, this could be taken on to assist not only protecting society, but protecting the individuals who are in court.
I fully agree. And in the US in particular, 10 to 20% of the people in prison have mental illness. And unfortunately, in the US, they don't get treatment. And often they're never let out again because they are not improving. And it's not quite the same in the UK or in Europe. But there's a lot of morbidity in prison. I've worked actually in that sort of population when I was a drug and alcohol consultant for a while. And yeah, I would love to do that. We haven't explored that ourselves yet. We are in the NHS, and I can tell you it's very, very difficult to, because you have to negotiate with each trust individually. We're now looking at the private sector, but we would be very, very interested prison population, and we have discussed it, but we haven't got the right connections yet. So if you have connections and know someone who would be interested, we would definitely be interested to talk to them.
Let me try the first of the, got three questions online. Tessa Covington Shaw, schizophrenia also has a diagnosis problem. How does that relate?
Yes, so I worked very intensively on schizophrenia, and this was a test which I developed and talked about by my first company. The problem with schizophrenia is that patients often have not a very good insight that there is an illness. So therefore, they would not be readily engaging in doing a digital assessment because they don't believe there's something wrong with them. And that makes it very difficult. We do assess psychosis, and when we did trials, we had several patients with schizophrenia, usually partly treated, who also did the assessment, but it is more difficult just because of the nature of the illness, but they don't believe there's anything wrong with them. So they're also paranoid. Very often paranoid schizophrenia is the most common form of schizophrenia. So they would probably be very worried about answering questions and would believe that something awkward will be happening to them. So that's a problem with schizophrenia.
Let's take a question from the floor.
My name is Dr. Keith Redhead.
Mm-hmm.
I'm a general practitioner, or at least I was. Your research confirms the benefit of very high quality psychiatric assessment and the delivery of this personalized psychoeducation. To what extent does your research confirm the biological nature of bipolar disorder, which I know that's your interest, isn't it?
Well, the digital assessment is really quite old-fashioned in that we are going back to the symptoms, and those seem to still be the strongest markers for the disease. So we have these biomarkers, the ceramide, some of the glucose and metabolism, but it's not as strong as the symptoms. And with all my efforts over a couple of decades, I can't say we are there yet. I don't think I'm there, nor anybody else. The symptoms are still the strongest predictors of the disease. The ceramide is exciting and encouraging, but a lot of more work has to be done. For example, to look, is it responding to intervention? Because that would be great. Because many times we treat someone with a drug for a long, long time. If we know earlier that this drug is not likely to respond because the biomarker is not normalizing, that would be a way of a personalized treatment approach, but we are not there yet. Very good question, yeah.
What makes you think I'm sure you're right.
Mm-hmm.
No one could do. What makes you think that it is biological? I'm quite sure you're right about that, but why are you so convinced?
Well, there's a strong genetic component, first of all. The concordance rate amongst identical twins is 80%. And also if they were brought up in different families, so there seems to be a genetic basis, and the genetics is also translated then into proteins and into metabolites, and this is what we're seeing here. There's also the association with other disorders, particularly very high rate of diabetes, type 1 and type 2, much, much greater amongst patients and also their first degree relatives, and also other conditions. There are sort of a lot of telltale signs, which I think make it very likely, but particularly the genetics.
I've got, I'm going to interleave the online questions because we're getting lots of interest. So Haichao Wang, first of all, says great talk, of course. Two questions. One really about whether the dry blood spot testing was using established protocols or whether you did some development. to
No,
get that to
it
work.
is established protocols. Everything had to be CE marked, a CE marked blood spot collection kit, you know, sort of, and filter papers as well. This is necessary in order then to develop a proper diagnostic test from it. Otherwise, you would have to start from scratch and redo everything. So yeah, everything was protocoled and under ISO 13485.
Indeed. And then the separate question, what were the challenges during patient recruitment or to get patient recruitment?
We had a lot of interest, you know, at the beginning it was very slow, and my team always knows I'm always sort of watching. And then we had sort of lots of patients coming through simultaneously that we had to switch it off as well. We could not send out enough blood spot collection kits within such a short time because we had waves, and it looked that way. Did we certain Facebook advertisements sort of created a hype, and that we had sort of waves, and then it would go down again, then it would be the next wave, and that was sometimes quite difficult. So the team was rotating around. You know, we had to put all the kits together ourselves and send it out, receive the samples. Also, sometimes the envelopes of the blood spot collection, envelope that came back was blood smeared. So the receptionist got very worried. So we had to deal with that and had to put in different boxes because people in chemical engineering are not used to sort of biological samples. So we changed the envelopes as well so that it was less likely. There were lots of drama on the way.
Let's take a question.
Hi, Geraldine, and I'm also a retired GP. I was just slightly concerned. It goes back slightly to the question about the schizophrenia, that where you have patients with psychosis with poor insight, whether they have, for example, a depressive and potentially paranoid psychosis. Well, one question is, can some of those patients actually flip into a bipolar situation? And also, if you have someone who perhaps has a higher hypomanic psychosis, that is there a risk about sending out these questionnaires with loads of questions that might upset those who have poor insight?
Yes, that's a very good question. We always collect feedback. I think someone who's very paranoid and disorganized will probably not be able to go through sort of hundreds of questions. There is always a risk, and we always tell people, if you feel stressed, you know, sort of put it aside, you can come back anyway. There's also a button, you know, if you feel unwell, if you feel you can't cope, you know, there are all the information. You can call the Samaritans, you can call 111 option 2 in the UK, go and see your GP. So all of the advice, but we sort of tell people to stop if at any time they feel distressed or upset, or if this is bringing up memories. By the traumatic history, we also let them opt out, you know, so this is, we don't want to trigger. But I fully agree that even asking about past symptoms could potentially be triggering. Has not been sort of a major problem as yet, as we have heard from our patients, but it's something to be aware of course, yeah.
Obviously, if you have good selection,
Pardon?
presumably, if you have good patient selection, you might avoid this, but I think the whole idea of
They're
this,
selecting, you know,
No.
so the NHS is sending this out to anyone, but the alternative is they will be triggered by someone asking it face to face. It's probably not much different. It may be better to do it where you can put it away if you feel upset and you can come back to it. It's the question, what is more triggering?
We've got lots of questions and I'm getting more and more on the pad here.
Sorry. Thank you for your talk, Professor Bahn. I'm Kate, I'm one of the doctors from Addis. I've got a few questions. So the first being, have there been any trials or any studies looking into either mitochondrial deficiency patients or any patients with essentially glucose metabolic disorders that have also had high correlation with the psychiatric disorders that you've mentioned?
So the mitochondrial dysfunction.
Yeah, so have there ever been any studies in the past where they've just isolated that particular cohort and then found a correlation with psychiatric disorders from a clinical kind of approach?
Yes, good questions. It's mainly in large cohorts. So not only our group has found these mitochondrial abnormalities, but many others as well. But it's not specific patient subgroups. I don't think we're going into any great depths here. It's mainly in the post-mortem brain, and you don't have thousands of post-mortem brains. Most of us use similar brain banks, and there are hundreds, a few thousands, but not enough to subgroup. The big problem with post-mortem studies is also that there are limitations, because most psychiatric patients did not die of natural causes unless you take very elderly patients. But the Stanley Medical Research Institute has mainly people who were between their 20s and 50s. So many of them died by suicide. So this could have impacted on the brain as well, whilst the control the control group, they often died by accident. So they're different means. So one has to be careful by over-interpreting and starting to subgroup something which is difficult to control for.
I'm sorry. Oh, sorry. Okay, which one then? What was the exclusion criteria for the Delta trial?
For the Delta, it was people had to be resident in the UK. They had to be between 18 and 65, not breastfeeding or pregnant, not suicidal at the current time of doing the Delta study, because that was obviously problematic, and no blood-borne disease which could have influenced the biomarker signature. I think these were the sort of main criteria, inclusion criteria. And then obviously with the depressive symptom at the time of presentation, either within low mood or depressive mood. We did not want to look at people who are manic, for example, because that would be a parameter which we would not be able to control for properly. So, and this is also not when people usually present to their doctors, they usually present when they're depressed.
So there are a couple of questions coming up about who can get access to these trials. Are they commercial clinical trials?
No, we're doing them through the university. We're just doing now a validation study for the bipolar biomarker signature. We're just going through the ethics approval, and then we will be recruiting through Facebook again, and people who are interested can watch the website. As I say, it will take some time.
But it would require a clinician to decide this was an appropriate course of action. It wouldn't be just available on.
No, not. Well, it could potentially be sort of, but we would see it as an add-on to the diagnostic assessment. And only once it would be validated widely, sort of, and you could really be clear about the diagnosis, would you be able to give something to patient? It wouldn't mean anything to someone. Your ceramide level is of a certain level. Yeah, you have to be careful here, and you can't jump.
Okay, I think that's picked up a couple of points that are picking up here. It's a question about what proportion of substance use disorder patients sort of cross into your field of view.
Quite a lot. It's particularly highly comorbid with bipolar disorder, with the impulsive behavior. You often have substance current.
So bipolar disorder sets you up to be more likely to be a substance abuser. Yeah.
It's higher. Also with depression itself, medication, just having a glass of wine, you're not feeling too great, and then that can escalate, but particularly bipolar disorder. Yeah.
It may be slightly off topic, but I was absolutely astonished a couple of months ago to read something that suggested that something like 25% of the population, that might have been the adult population of Scotland, were on antidepressants. And I'm wondering, listening to you, whether that really might be not necessarily the most constructive way forward. I suppose I also wonder whether there might be something like a talking therapy that might be more helpful. But
yes, yeah. Well, it's the prevalence rate of depression is 6-7%. So maybe 25% have been at some time on antidepressants, you know, unless it's very prevalent, maybe where there's little light in the winter, over the winter time, or seasonal affective disorder. But yes, you know, in mild to moderate depression, talking therapies can be very effective and should be a choice, but it's also the choice of the patient. The patient should be able to choose. If you don't want a talking therapy, there's no point in doing it. It will probably not be effective. If someone says, I'd rather try a drug, I'm happy to try it out. Why not? And also if they have severe sleeping problems, some of the antidepressants help people to sleep at the same time and are less addictive than sleeping pills. And that can be a way forward. And there are lots of positive aspects. If you look at animal models where you induce a depressive state and you give them antidepressants, it increases the neurogenesis. So it's not a bad drug. They don't have sort of terrible side effects necessarily. I think there's a lot of myth that antidepressants are not good for people and many of them are quite good and helping people. And if someone is depressed for a long time, their cortisol levels will be very high, and associated with high cortisol level is also changes in the brain and also loss of nerve cells. So the antidepressants can even prevent that. So I think it should be a choice. Patients need to be informed what their choices are, what the potential side effects, what the effectiveness is, and then they should be able to choose and make their own informed decision.
Thank you for the talk. So I'm kind of interested in the ethnic diversity within the samples, because there are some research find that the manifestations and symptoms of mental health, especially depression, can vary in different ethnic groups. So how would that be reflected in your study? Like, are there different biomarkers?
Yeah, very, very important point. And unfortunately, with our recruitment strategies, we are typically recruiting white people, mainly female as well. So in the Delta study, we had to try very hard to get at least 30% of men into the study by targeting them. It's very, very difficult to get men. You know, if you just advertise without any structure, you probably get 95% white women, usually of a higher social class and good income, because we're assessing that as well. So we want to target sort of diverse population, but it's difficult. In the GP study, this was in a more deprived area in London where there's much more ethnic diversity. There we were able to assess it in a smaller sample. And it was very positive because people said, particularly if their first language wasn't English as well, sort of this was easier. We have a reading age of 10, 11 in the questions, because if a psychiatrist stands in front of you and maybe uses complex language, they may not be able to understand it. Here they can take their time. We try to pose the question in a simple language and they can answer it better. Ultimately, it should be also translatable. Eventually, this will be a feature and should be at the click of a button. You can sort of read it in any language. And I think this will be important, but you're absolutely right. Ethnicity is very important. Social deprivation, all sorts of factors play a role, and we need to get more data on that for sure.
Thank you.
You've partly answered my question just now, but what level of literacy is required to complete this thing?
Yeah.
People can be very skilled at covering up the fact that they aren't very literate. And in terms of the population as a whole, what percentage is that excluding? And presumably these are the people who might end up in prison, because as I understand it, a lot of prisoners are very poorly literate.
Yeah, and we could even make versions which are less complex, even shorter sentences, and we're working on that. There's still work to be done. You know, we are changing the product as we go along, and we're getting the feedback as well. So we want to have feedback. We do a PPI group, so we engage people with lived experience. Every single question that is in the questionnaire was assessed by many, many patients, and they gave us lots and lots of feedback, what we should call something. They don't want to be called a disease, but a condition, and not questions which imply that it is their fault, you know, sort of you are to this or to that. You know, we are avoiding these sort of labeling statements where people feel they're sort of put into a box. We're doing our best. We're probably not perfect yet, but this is where we really want to work with people who are using the product.
Briefly go back to the online. Here's a fun question. A popular moisturizer, this is Tessa Cohen-Shaw again.
Ceramide.
It contains ceramide.
Yeah.
Is it good, bad, or doesn't it matter? I'm paraphrasing.
Well, I actually sort of, yeah, I use a cream with ceramide as well as most
Okay,
women of a certain age who want to risk.
It must be good then, yes.
Exactly. No, I'm quite interested how much of that ends up in the blood, but we are controlling obviously for gender, age, and sex, and other parameters. But it is you know, I was asking exactly the same question.
Great.
Good question.
Mine's a very brief point, which is that given the means by which you're presenting the questions to people, it's entirely possible to have them recorded as spoken questions. People do not need to be able to read them.
Yeah, I think these days should not be too complicated to have it read out. But it's a feature, you know, which we have to work on. At the moment, the thing we are struggling with, and well, which we're achieving, is to integrate it into electronic health care records. So this is the first thing, you know, they're first and then second. So we're working our way through it. But I think this will definitely be an opportunity for people who can then listen to it if they feel easier to comprehend language in a voiced way rather than reading it. Absolutely should be pretty straightforward. There's software available sort of to integrate, but then you have to test it and make sure it works properly. Absolutely. Thank you.
I mean, I'm sure you could carry on. It's a wonderful talk, and the range of questions is, I think we sort
Yeah,
of.
thank you so
just-
much for fantastic questions. Really
Yeah.
exciting.